Hello, my name is Dr. Yasser Ahmed Noor. I'm a professor of otolaryngology at the Faculty of Medicine, Alexandria University. The lecture is about the disorders of smell or the fifth sense. The sense of the smell is an under-recognized sense. You don't feel the importance of the sense of the smell unless you lose it. So it is an under-evaluated sense. The objectives of this lecture will be as follows. By the end of the lecture, each student should be able to recognize the effect of smell disorders on the quality of life, to illustrate the olfactory pathway, to list the various types of smell disorders, whether quantitative or qualitative, to differentiate between the causes of smell disorders based on clinical data, to identify the needed investigations based on suspected cause of smell disorder, to select the appropriate treatment. So let's go step by step through the disorders of smell. First of all, the effect of loss of smell on the quality of life. If you lose the smell, you are going to lose the taste, and this will result in inadequate nutritional intake, which will result in reduced social pleasure and decreased psychological well being. There are many people who are losing the sense of the smell. They are suffering from a state of depression because of the loss of the sense of the smell. They cannot taste the food, they cannot smell anything in the nature, such as flowers, or sometimes they are affected because they lose the memory which is related to certain odors. At the same time, it might be a life threatening. If you don't have a sense of smell, you will not be able to detect that there are fumes from a fire or a leaking gas. If you lose the sense of the smell, you will not be able to recognize that the food has been spoiled, and this might result in many problems. In addition, many occupations might be affected by the loss of the sense of the smell, such as those working in perfume factories or cookers, because they rely on the sense of the smell to detect the quality of the materials which they are working on. So their work might be affected by the loss of the sense of the smell. I will give a brief description of the olfactory system. The nose has many functions. Air, while it flows through the nose, it will undergo several changes in order to prepare it to transmission to the lungs for adequate gaseous exchange. The air will be filtered, there will be humidification and temperature control. The inspired air is carrying also the odors. These odors will be detected by the olfactory system or the olfactory neuroepithelium, and there will be a chemical reaction. And this chemical reaction will be translated into a nerve signal that will be transmitted to the brain. So it is logic that the peripheral element of the olfactory pathway to be located on the roof of the nasal cavity and on the upper part of the lateral nasal wall on each side, because this is the closest area to the brain. The olfactory neuroepithelium is made of pseudostratified columnar respiratory epithelium, and it is about 22 centimeter square in surface area. The olfactory signals will be detected by the olfactory epithelium and then will be translated into a nerve signal, and the nerve signal will be carried by the nerve fibers, which are located in the cribriform area, to be transmitted to the olfactory bulb, which is the first part of the central olfactory pathway. So as we can see here in this slide, the olfactory neuroepithelium, which is made of pseudostratified ciliated columnar epithelium, and you will find nerve endings within the neuroepithelium. The nerve endings will pass through what we call the cribriform area of the skull base of the roof of the nose in order to reach the brain. So the olfactory cleft contains roughly 6 million bipolar olfactory receptor cells. Those cells will continuously regenerate from horizontal and globose basal cells located within the olfactory neuroepithelium. And this method of regeneration is continuous through life and after trauma. And this gives the good prognosis after viral infections and after trauma, which will affect the neuroepithelium, giving a hope for regeneration after those insults. And as you can see in this picture, the olfactory bulb will host many synapses, transmitting the nerve signals to the central olfactory pathway. These bipolar receptor cells, they act both as a sensory receptor and the first order neuron, which will carry the nerve signals to the central olfactory. The olfactory neuroepithelium is very complex in its structure, and each receptor expresses a single odor receptor gene. And roughly we have 1,000 distant transmembrane G protein olfactory receptor genes, which represent almost 3 to 5% of the entire mammalian genome. So we can detect almost 1,000 odors because of the complexity of the olfactory neuroepithelium. And in this slide, you can see the olfactory neuroepithelium and the olfactory fiber passing through the cribriform area to reach the olfactory bulb, which is harboring a lot of synapses in order to prepare the signal to be transmitted to the central olfactory pathway. This slide is showing the central olfactory pathway. As you can see here, the olfactory neuroepithelium, which is located in the roof of the nose, and the olfactory fibers passing through the cribriform area. The chemical odors are sensed by the olfactory neuroepithelium, initiating a nerve signal which will be transmitted through the olfactory fibers to the olfactory bulb, and the olfactory bulb will transmit the signals to the concerned area of the brain, including the primary olfactory cortex, which is the base of the frontal lobe, and the medial temporal lobe, thalamus, orbitofrontal cortex, and the limbic system. So it is a complex system. You sense a smell, and this will induce a lot of reactions, including sympathetic response, emotional reactions, memories, and many things in the brain related to the sense of the smell. That's why when some patients lose the sense of the smell, they go into a state of depression. And at the same time, some of the neurodegenerative disorders, as we are going to see later, are first manifested by the loss of the sense of the smell. The trigeminal pathway. As we all know, the trigeminal nerve is a sensory nerve. It supplies the nose and the nasal mucosa with sensory fibers that will detect the chemical stimuli but not the odors. So the fibers of the trigeminal nerve or the fifth nerve innervate the entire nasal cavity and can sense tactile, pain, temperature, and nauseous stimuli. And those stimuli often will result in a reflex response in the nasal mucosa in the form of mucus overproduction, mucus congestion, or mucosal congestion, sneezing, and this will can indirectly affect the olfaction by causing nasal blockage and preventing the airflow to reach the olfactory neuroepithelium. So the trigeminal pathway is responsible for the common sense, but sometimes it is very helpful in detecting true loss of the sense of the smell from malingering, because in those patients who are having total loss of the smell, they can still detect strong nauseous stimuli such as ammonia, which is conducted through the trigeminal pathway. In addition, the trigeminal pathway may be important in the regeneration or the recovery of the sense of the smell, because usually we advise the patients who are having loss of the sense of the smell to train their sense of the smell, to do what we call odor gymnastic. They have to try to smell odors because there is a sort of neural plasticity. The signals might be taken by the trigeminal pathway instead of the olfactory neuroepithelium to the concerned area of the brain, and this might help in the recovery of the sense of the smell. So let's discuss the types of olfactory disturbances. First of all, the quantitative olfactory disturbances, which mean a defect in the threshold of olfaction. We have normosmia, which is subjectively perceived normal olfactory function. We have hyposmia, which is the decreased ability to detect odors, and anosmia, which is complete inability to detect odors or complete loss of the sense of the smell. We have also hyperosmia, which is an abnormally acute smell function. In some epileptic patients, they will experience hyperosmia prior to the onset of ictal activity, before the seizures. So this is very important on those type of patients. Then we have the other group, which is the qualitative olfactory disturbance, which is the disturbance in the quality of the sense of the smell. This is called dysosmia, or distorted or perverted smell perception, which means there is something and you smell it as something else. For example, abarosmia. There is an altered perception of the sense of the smell in the presence of an odor, and it is usually unpleasant. Sometimes they call it cacosmia. For example, if there is a rose, you smell it as a garbage or a bad odor. Phantosmia, or what we call a hysterical olfaction. You sense that there is a smell in the absence of any odor, and this is called phantosmia. Phantosmia, which means olfactory hallucination, olfactory hallucination. So we have an example: a rose smells more like a garbage than a rose, a medicine-like smell present in the absence of an odor stimulation, which is a typical of phantosmia. What is the prevalence of olfactory disorders? Many studies showed that the prevalence of self-reported smell loss varies between 1.4% to 15% across those studies. But if you go and do screening for a wide range of the population, you will find that this prevalence is much higher. It might reach 2.7 to 24.5%. So this means that many people are unaware of the loss of the sense of the smell, are unaware of the decrease in the sense of the smell. They under-evaluate the sense of the smell. So regarding the preference, it is a fairly common problem. What are the three most common causes of olfactory disorder? They are either sino-nasal disease, post-viral anosmia, and head trauma. Post-viral anosmia. Whenever we have a cold, it is very common that the patient will come to complain about the loss of the sense of the smell. It is mainly due to the nasal congestion and the edema of the nasal mucosa, which will block the flow of the air to the olfactory neuroepithelium. This is a conductive way of the loss of the sense of the smell. But at the same time, the virus itself might induce a damage to the olfactory neuroepithelium and will cause what we call a perceptive loss of the sense of the smell. The good news that the spontaneous recovery is expected in 2/3 of the patient. So whenever you have a patient with a cold, you have to tell him that the sense of the smell might recover, and there is a high incidence of recovery, which is might take about 1 month or 2 months after the resolution of the cold. The second common cause of olfactory dysfunction is trauma. Trauma might induce a sinonasal tract disruption causing septal deviation or a septal hematoma, which will block the transmission of the uh, olfactory signals toward the olfactory neuroepithelium, or the trauma might affect the cribriform area, resulting in an olfactory nerve injury, which is called a shearing effect because of the passage of the olfactory nerve fiber within the narrow holes of the cribriform plate. Or the trauma itself might induce a concussion in the brain. So, following trauma to the head, it is common to have a loss of the sense of the smell. One third might recover spontaneously. Recovery becomes less expected after 1 or 2 years, which denote irreversible injury to the olfactory pathway. So, in comparison to the post-viral anosmia, the post-traumatic olfactory dysfunction is having a less incidence of spontaneous recovery. What about the sino-nasal diseases? Many sino-nasal diseases might be associated with olfactory disturbance, either due to a conductive cause or a perceptive cause. We have septal deviation. This will cause a conductive decrease in the sense of the smell because of the blockage of the airflow to the olfactory neuroepithelium. Then the allergic and the vasomotor rhinitis, they can have both a conductive effect and a perceptive effect because allergy might induce edema and inflammation within the olfactory neuroepithelium itself. Then the chronic sinusitis with and without nasal polyps. The polyps might cause a conductive block to the flow of the odors to the olfactory neuroepithelium, or the chronic inflammation might affect the olfactory neuroepithelium, causing a perceptive loss of the sense of the smell. Any nasal granuloma or any nasal tumor might cause a conductive loss by blocking the flow of the odors to the olfactory neuroepithelium, or when the granuloma or the nasal tumor invades the area of the cribriform plate, this will cause a perceptive loss of the sense of the smell. So the anosmia associated with chronic sinusitis, again, it is either due to the blockage of the inspired air, due to the nasal congestion, which is associated with edema and infection and causing the conductive olfactory loss, or a perceptive loss due to the effect of inflammation on the olfactory neurons. Another cause of anosmia is aging. Normal aging is associated with decreased sensitivity to smell. As individuals age, they lose the number of cells in the olfactory bulb as well as the olfactory epithelium, and the ability to regenerate after trauma or viral infection is also less. A very important association is between olfaction and neurodegenerative disorder. Olfactory dysfunction in cognitive normal person could represent preclinical neurodegenerative disorder. It might be the early symptoms of a neurodegenerative disorder, and it is useful as a part of the preclinical detection strategy and for enrollment in neuroprotective therapeutic strategies. For example, in idiopathic Parkinsonian disease, together with tremors, rigidity, and akinesia, olfactory dysfunction is a prominent symptom of idiopathic Parkinsonian disease. The olfactory disturbance is thought to precede the motor symptoms by about 4 to 6 years. So, idiopathic Parkinsonian disease should be considered in at least some cases of idiopathic olfactory dysfunction when there is no history of trauma, there is no history of chronic sinusitis or viral infection, particularly in patients who display rapid eye movement, sleep behavior disorder, or depression. Another neurodegenerative disorder which is associated with olfactory disturbance is Alzheimer's disease. Progressive loss of olfaction can be considered an objective diagnostic indicator in the earliest stage of Alzheimer's disease, as it occurs in approximately 90% of the patient and correlates with disease progression. Another Neurodegenerative disorders include schizophrenia, multiple sclerosis, temporal lobe epilepsy, Huntington's disease, HIV-associated dementia, amyotrophic lateral sclerosis. There are some people who are born without a sense of smell. This is called Kallmann syndrome. There is complete anosmia from birth. It affects 1 to 10,000 males and 1 to 50,000 females. And anosmia is probably due to the failure in the development of the olfactory bulbs, and the olfactory epithelium itself is abnormal histologically. So it affects males more than females, and the sense of smell can be impaired or absent. It's a genetic disorder. There are associated another symptoms, which is hypogonadotrophic hypogonadism. Secondary sexual characteristics are delayed in both males and females. The syndrome may be associated with audiological abnormalities, color blindness, synkinesia, mental retardation, cryptorchidism, osteopenia, obesity, cleft palate and palatal cleft abnormalities, renal agenesis, metacarpal abnormalities, cardiac and intracranial abnormalities. So whenever you have a child with a loss of sense of the smell and the parents are complaining that the child cannot detect odors, think of the Kallmann syndrome, because this is a genetic disorder which can be treated by hormonal replacement therapy. What are the other causes of smell disorders? There are various causes of smell disorder which you should include in your history taking, including cocaine abuse, toxic chemical exposure in some occupations, industrial agent exposure like chromium, iron carboxyl, lead, nutritional factors including vitamin deficiency, trace metal deficiency including zinc and copper, malnutrition, chronic renal failure, liver diseases, cancer, acquired immunodeficiency syndrome, radiation treatment of the head and neck. Neoplasms, either neoplasm of the nasal cavity blocking the access of the odors to the olfactory neuroepithelium, or a neoplasm involving the area of the olfactory cleft and the olfactory bulb, including olfactory groove or cribriform plate meningioma, frontal lobe tumor, temporal lobe tumor, which affect the central pathway of the olfaction, pituitary tumor, olfactory neuroblastoma, melanoma, squamous cell carcinoma, psychiatric condition, malingering, schizophrenia, depression, olfactory reference syndrome, endocrine disorders including hypothyroidism, Cushing's disease, diabetes, Turner syndrome, pregnancy, epilepsy, migraine headache, which is causing olfactory aura, cerebrovascular accident, Sjogren's syndrome, systemic lupus erythematosus, and some medications. And it is very important to include it in your history taking, because some medications are taken and they might be the cause of the olfactory disturbance, like the calcium channel blockers, lipid lowering drugs, antibiotics, and antifungals, antithyroid medication, opiates, antidepressants, antiepileptics, and nasal decongestants. What about the diagnosis? The diagnosis should be based on the history, the clinical examination, imaging modality, blood workup. Of course, you don't need to do all the imaging modality and the blood workup to every patient, but you have to select the appropriate investigation based on the clinical data. If you suspect a nasal tumor or an intracranial tumor, you have to order a CT scan or an MRI. If you suspect a systemic disease, which might be the reason for the olfactory disturbance, you have to ask for a blood workup. And you can objectively assess the smell by using a threshold testing test, or the most common test, which is called the University of Pennsylvania Smell Identification Test. We give the patient an odor and we can test the threshold of his smell. We can test which type of odor has been lost and the threshold of the smell to each type of odor. So this is regarding the diagnosis. So based on the history and the clinical examination, you can select the appropriate investigation which needed for such particular patient. What about the treatment? The treatment is based on the identification of the cause and the treatment of the cause. You can try oral steroids for 7 days, intranasal steroid spray to improve the inflammation within the nasal cavity and to increase the access of the odors to the olfactory neuroepithelium. And as I mentioned before, olfactory training or odor gymnastics will help the neuroplasticity to develop, to find alternative pathway for olfaction. Surgical therapy is indicated only in cases of conductive loss of the sense of the smell. For example, doing septoplasty for a marked deviation of the septum, doing a functional endoscopic sinus surgery to resect the polyps, doing a tumor resection to improve the airflow. This will help in the flow of the odors to the olfactory neuroepithelium. Some other medications are used, but without any proven efficacy, including zinc replacement, herbal remedies, some other medications which will improve the regeneration of the nerve endings, such as the alpha lipoic acid and carovarine. And what is under investigation and what is giving hope for some patients to regain their sense of the smell is the gene therapy for congenital olfactory loss and the olfactory stem cell therapy to help in the regeneration of the damaged olfactory neuroepithelium. So to sum up, the sense of the smell is important in your quality of life. Whenever you lose your sense of the smell, you will have an impaired quality of life, which will affect many factors or many domains of your life. And you have to look for the causes of the loss of the sense of the smell. And the most common are the post-viral, the post-traumatic, and the sino-nasal disease. Don't forget that some neurodegenerative disorders are associated with a loss of the sense of the smell. This might help those patients to start the treatment early if you detect them early. And then in the diagnosis, select the appropriate investigation based on the clinical data. And this is the available treatment up till now for those cases who are suffering from the loss of the sense of the smell. Thank you very much. Enjoy your sense of the smell. Smell the nature. Smell is a potent weather that transport you across thousands of miles and all the years you have lived. Thank you very much.